for inviting me to present on thigh injuries in elite football. I'm aware of the excellent work being done in Egypt to drive standards in terms of the provision of sports medicine, and I'm delighted to be able to contribute to that with my presentation today. So my name is Dr. Sean Carmody, and I'm going to present on thigh injuries in elite football. And in that, we're going to cover two big muscle groups, so the hamstrings and the quadriceps muscles. So what we'll cover today, we'll go over how common these injuries are. We'll cover a little bit about the anatomy and how that's important when we consider assessment of these injuries, and also with respect to rehabilitation and what can make them a little bit tricky to manage. We'll cover the most common mechanisms of injury, the clinical features, and then imaging. And what will be important in terms of imaging is some of the classification methods that are used for muscle injuries. And I'll kind of talk about the most common one we tend to use in the UK. And then we'll cover the basic principles of rehab, but I think that really could be a presentation on its own, so we won't go into too much detail around that. So quadricep injuries, they make up about 19% of muscle injuries and 7% of severe injuries in elite football. And the most commonly affected muscle from the quadricep muscle group is the rec fem muscle. Re-injury rates are at about 17%, and we know that when you have a re-injury for any muscle injury, not just quad injuries, you tend to get it tends to take much longer for players to return to play. In terms of the anatomy, so the quadricep muscle group is made up of the rec fem, the vastus lateralis, the vastus medialis, and the vastus intermedius. And as I said, the most commonly implicated muscle there is the rec fem. It's a biarticular muscle group, which means it involves the hip and the knee joint, and that's obviously very important with respect to the assessment of this injury. And its most important function is to extend the knee, flex the hip, but it also plays a role in stabilizing the pelvis on the femur. And the femoral nerve is the nerve which is supplied to the quadricep muscle group. It's a bipennate muscle, so that's very important for high force production. And if we think in terms of the big role it plays in terms of acceleration and kicking in football, and it's got two proximal heads of origin, which is important anatomically. So the most common mechanisms of injury for quad injuries in football is during acceleration and in kicking, and that's in the swing phase or at ball contact. Commonly, you'll see a player pull up after an acceleration, and they'll be putting their hand around their quad area, or even after kicking. And it's often an increase in kicking load, which can contribute to a player injuring their quad, or an unaccustomed increase in a kicking load. And that might be due to a change in what they're doing in their training, or it might be reflective of and a different a change in position, for example. Deceleration, again, it's another particular mechanism of injury for quad injuries, but it's less common than acceleration and kicking. So the most common clinical features of rec fem injuries, and this probably applies to other muscles within the quad group as well, but you classically get pain, you get a loss of range, especially in prone knee bend, and you get reduced strength. You also need to be mindful of the more subtle quadricep injuries, which might just present with some vague tightness or a slight loss of range. And those kind of injuries, if not managed carefully, can progress to a more extensive quadricep injury with a longer return to play time. Typically, a player will report a sudden onset of pain when they accelerate or when they strike a ball. Objective clinical assessment, it might reveal tenderness to palpation. There's occasionally a palpable indentation, and often clinicians are quite taken aback by this, but that can be a common sign of a quadricep injury. and then there's reduced strength and on quads testing, straight leg raise, and functional movements such as lunging. I think for most muscle injuries, it is a clinical diagnosis, but it is supported by the findings on imaging. So the most important thing is the history and exam, as with most things in medicine. So taking a good history from the player and reviewing any footage if it's available and relevant, and obviously clinical examination. And then that will guide what you want to look for with respect to imaging. Now, not all muscle injuries necessarily need to be imaged, but for more extensive injuries or where there's some diagnostic ambiguity, you may want to consider imaging. And for muscle injuries, for quad injuries, the most commonly used are ultrasound and MRI. Ultrasound is very user dependent, but what's helpful about it is that you can image dynamically and you can do serial images throughout the return to play process, which can be useful and provide confidence to the clinician and the player during the return to play. MRI ultimately is the most sensitive and most effective imaging method for muscle injuries, but it's not very freely available. Obviously, there's an expense attached to it, and we, as I said before, we also always must be guided by our clinical findings and using the MRI to support that. Where MRI is quite useful is at getting a very specific diagnosis, and also we know using specific muscle injury classifications, the most kind of commonly or well supported muscle injury classification in use at the moment is the British Athletics Muscle Injury Classification. And that can be useful, as I said, to diagnose, but also to determine the prognosis for the injury. For the number would refer to the extent of the injury and disruption to the muscle fibers, and then the letters would refer to the site. And the one we would be concerned mostly about is that C injury on the BAMIC classification, which refers to a tendon injury, and that's associated with a much longer return to play time and a higher recurrence rate. So it can be very useful for an MRI to include or exclude an intratendinous injury, because then that will help to provide reasonable expectations about the return to play time, and also just make sure we manage that a little bit more cautiously in terms of return to play, because of the risk of recurrence. And there's a very useful paper there by Peter Bruckner and David Connell which deals with these types of injuries. So as I said, when it comes to rehab, we could go into huge detail on this, but I won't. I'll just be provide a very brief overview. And with muscle injuries, often we'll speak in terms of time, but actually, crucially, it's criteria driven, and they need to be able to, perform their sport specific movements, graded return to accelerations with respect to quad injuries is very important, and also progressive return to kicking is exceptionally important when we consider rec-fem injuries. Basic principles are to reduce pain in the acute phase, increase length, increase strength, and then ultimately maximize function. And function with respect to a footballer is what they do on the pitch. Really useful paper if you want to look into this in a lot more detail, by Chris Morgan and his team at Liverpool Football Club, who it's a freely available paper, who go into a case study on the management of and rehab of a rec-fem injury in kicking athletes. So in summary, when it comes to quad injuries, it's a common injury in football. It's a biarticular muscle group related to the hip and the knee, and injury is classically characterized by pain, reduced strength and range. The most common mechanisms are in kicking, so suddenly feeling pain when the player kicks, accelerating, or less commonly deceleration. Imaging can be useful, especially with respect to intratendinous injuries, and when it comes to rehab, we should always be criteria driven and not necessarily time driven, but we should pay respect to the biological tissue healing, and in that respect time is important, and especially for the intertendinous injuries. So the other major muscle group in the thigh is the hamstring injury. So we'll go through hamstring injuries a little bit in the same way we went through quadricep injuries. We'll cover how common they are in football, and we'll look at the anatomy. We'll look at how these injuries tend to happen, the clinical features, the role of imaging, again, the basic principles of rehab. And I think we'll cover a little bit on prevention, because there is a lot more, certainly a lot of high level evidence around preventative methods for hamstring injuries in football. With all muscle injuries, they are preventable injuries, and there's lots that you can do to be proactive to reduce the burden of these injuries. So hamstring injuries, they are the most common injury in football, accounting for about 12% of all injuries. An elite club can expect up to 6 hamstring injuries per season. So that has a significant financial burden when you think that at some of these clubs, the players are on huge salaries. So the more time they spend on the treatment table and not on the pitch, the greater cost that has to the football club. So there is a great financial incentive there for medical teams and performance teams and coaching teams to work together to reduce injuries. The most commonly affected muscle is the biceps femoris muscle, which accounts for about 80% of hamstring injuries. As you can see from Jan Ekstrand's paper there, hamstring injuries have increased about 4% annually. There is good reason for that, which we'll go into in a little bit. So in terms of the anatomy, the hamstring is made up of the biceps femoris muscle, and the biceps femoris muscle has a long head and a short head, the semitendinosus and the semimembranosus. It's innervated by the sciatic nerve, and its function is to flex the knee, extend the hip, and it also plays a role in medially rotating the thigh. And as with the quadricep muscle, it is also a biarticular muscle group. Hamstring injuries most commonly occur during accelerating or sprinting or accumulation of high-speed running, and you'll often see a player during the match, and this is Jozy Altidore during the World Cup, where it's very vivid. They're sprinting at full speed and then they stop suddenly, and they put their hand on their posterior thigh, are holding it and expressing pain. Deceleration again is another mechanism, as is change of direction, cutting, but they are less common than accelerating and high-speed running. But I guess the key thing to say is that the hamstring muscle group is most vulnerable to injury during eccentric actions. So in medicine, when we think about risk factors for any pathology, we think about modifiable and non-modifiable risk factors. So the non-modifiable things, the things we can't change, are age. So we know as players get older, they are at more increased risk of muscle injuries, and especially if they've had a previous injury. So previous injury is the biggest predictor of future injury. When it comes to muscle injuries, that's typically because there's often obviously fibrotic tissue around there. There's maybe the formation of a soft scar, which is weaker and more susceptible to injury, or a player may return to play too early, and that also increases their risk of re-injury. So previous injury and age are certainly the big non-modifiable risk factors. In terms of modifiable, I haven't listed it there, but fatigue obviously is important, and there's some really good studies showing that muscle injuries tend to occur later in the first half and the second half, which gives a good indication of football matches, which gives a good indication that fatigue plays a role in these injuries. Eccentric strength is very important, and the image there shows that the use of the Nord board testing equipment which looks at the eccentric strength of hamstrings for athletes. Carefully managing training load is very important, and of course it's coaches who determine the training load, so working closely with the support team and the performance support team and the coaches is really important from a medical team's perspective, so that we don't just exist and do, we only look after injuries. We have to work closely with the coaches and the performance staff and be proactive. Fixture congestion, so classically during the congested period in December, for Premier League footballers, often we see a higher rate of muscle injuries during that time. And I referred to it a little bit here, but communication is probably the most important thing you can do to help prevent or reduce the risk of muscle injuries. And by that I mean working well with the coaches, working well with the sports science staff and performance support team to make good decisions around players about when they should train, what they should do in terms of their training, and whether you need to be mindful of them during periods of fixture congestion. There's a really good video made available on YouTube, which will go through in 5 minutes an examination of a hamstring injury, and it's Dr. Mark Fulcher from New Zealand who goes through that. So that might be worth something you're looking up. But the examination of a hamstring injury, generally speaking, that subjectively the player will report pain on the back of the thigh. There's generally some tenderness to palpate. Occasionally you'll see bruising, but that's usually the sign of a much higher grade injury, and that will be quite a concerning sign if you were to see evidence of bruising in the area. And then you get pain with resisted movements in hip extension and knee flexion, and pain with passive stretching when the hip is flexed and the knee is extended. Similar to quadricep injuries, ultimately hamstring injuries, it's a clinical diagnosis and it's supported by your imaging findings. And certainly there is emerging evidence which is showing how useful MRI can be in terms of determining the extent of the injury, but especially in helping guide prognosis and expectations around prognosis. Ultrasound, as with quad injuries, it can be very useful to identify the affected muscle. It's obviously cheaper and more readily available than MRI, but ultimately it's very much user dependent. It should always be used in conjunction with your clinical findings. Gold standard for diagnosis of hamstring injuries with respect to imaging is MRI, and it can be used to diagnose and prognosticate, and using muscle injury classifications such as the British Athletics Muscle Injury Classification. Again, we could go into huge detail on principles of rehab, but we'll keep it very simple and kind of talking in big headings here when it comes to hamstring injuries. In the acute stage, it's just a case of protecting the injury, optimally loading. You would rarely need crutches, for example, when it comes to a hamstring injury, unless it was a very high grade injury where they're struggling to weight bear. Ice compression elevation certainly in the first 48 hours, and then once the player is pain free and able to get outside, you're looking at a criteria driven return to performance markers with progressive exposure to high speed running. Strength exercises, and especially eccentric strength exercises, are very important. And in terms of the principles of rehab with respect to football, you should always consider their position specific demands. So you should perform the rehabilitation of a striker who has a hamstring injury differently to how you might perform the rehab of a right back, for example. So you need to bear in mind the position of the player, because that becomes very important and can be useful in reducing the risk of re-injury. So I mentioned that ultimately all muscle injuries are preventable in some respect, but ultimately they happen. When it comes to preventing hamstring injuries, you should probably take a holistic approach. I mentioned things around communication being very important, strength being very important, managing training load being very important. But when we think about the evidence in the literature, the best researcher, most studied intervention is the use of Nordic hamstring exercises to reduce the risk of injury and re-injury and hamstring injuries in randomized controlled trials in amateur and professional footballers. It's shown to reduce hamstring injuries by up to 70%. And the underlying mechanism is that it increases eccentric strength and fascicle length. We know if a player is weak eccentrically and they have shortened fascicle lengths, then they are potentially at higher risk of a hamstring injury. You mentioned a little bit earlier about Jan Ekstrand's paper, which identified that hamstring strain injuries are increasing. This is thought to be that actually the training demands that players are put through day to day has increased a lot over the last few decades. And then when that's combined with possibly the poor adoption of injury prevention strategies such as the Nordic hamstring exercise, that might be a plausible explanation for why hamstring injuries are starting to increase. So in summary, hamstring injuries are the most common injury in football. The biceps femoris is the most commonly affected muscle in the hamstring group. It's a clinical diagnosis, but MRI can be very useful. When you're thinking about rehab, think about progressive exposure to high-speed running, and especially in the context of the position the player plays. And ultimately, it's a preventable injury, so you can be very proactive in terms of what you do and how you work with coaching staff and sports science staff to prevent these injuries. Thank you very much, and thank you again to Dr. Haytham for inviting me along to speak, and it's a pleasure and to do so. Thank you.